In this video, I'm going to discuss the clinical presentation of the spinal defects that are shown in these images. But before doing that, I would like to first go over the lesions of the dorsal column, spinothalamic, as well as the corticospinal tract. And once I've discussed those, then it would be easier to understand the phenotypes of patients that have these lesions in their spinal cord. So the dorsal column and the spinothalamic tract have three neuron systems. They have primary neurons that have cell body in dorsal root ganglion, secondary neurons that would decussate, and then finally they would go into the ventral posterolateral nucleus of the thalamus, and then after that they would go to the somatosensory cortex. Now the difference is that dorsal column is responsible for the perception of fine touch, proprioception, vibration, as well as pressure, while spinothalamic tract is responsible for the perception of pain and temperature. And then both of these systems, the dorsal column as well as spinothalamic tract, have a three neuron system. So first they would start with a primary neuron, then it would go into the secondary neuron that is shown right here, and then finally the tertiary neuron. Now, depending on where the sensation is coming from, whether it's coming from upper extremities or it's coming from lower extremities, the synapse at the lower medulla would be different. It would be in a different nucleus. So let me show you another image to clarify. So as you can see in this image, the lower extremities, their path is through the middle portion of the dorsal column, and eventually they would go into the gracile nucleus, while the upper limbs, their path is through the outer portion of the dorsal column, and then they eventually will synapse into the cuneate nucleus. So let me go back to the original image. So as you can see here, the feet, their sensation is going through the gracile fasciculus, and then they eventually will go to the gracile nucleus, while the hands, which are the upper extremities, will go through the cuneate fasciculus and then eventually go to the cuneate nucleus. So now let me explain the path of these nerves again. So the primary nerves will start from the tissue. They have the dorsal root ganglion here. They will keep on going until they hit the lower medulla, and they would synapse into either the cuneate or gracile nucleus. And then from there on, the secondary neurons will start, and as internal arcuate fibers, they would decussate at the level of lower medulla, and then they would keep on going until they hit the ventral posterolateral nucleus of the thalamus. And then from there on, as tertiary neurons, they would go to the somatosensory cortex. So let me show you what I mean by the somatosensory cortex. So here is an image of the brain. We have the frontal lobe right here, the temporal lobe, occipital lobe, parietal lobe, and the cerebellum. And then here in the frontal portion of the parietal lobe, we have the somatosensory cortex, which receives all the sensation from the body. And then in the dorsal portion of the frontal lobe, we have the primary motor cortex, which sends motor signals to different parts of the body. And that would be for the corticospinal tract, which I will discuss later. So regarding the dorsal column and the spinothalamic tract, they would both end up in the somatosensory cortex because they are both relaying sensory information. It's just that it's a different type of information. With the spinothalamic, it's pain and temperature, while with the dorsal column, it's fine touch, proprioception, vibration, as well as the pressure. And since the decussation was at the level of lower medulla, any lesion that happens below the medulla will have ipsilateral, loss of vibration, pressure, and fine touch, while lesions that are above the level of medulla, since there is already decussation and the nerves has gone to the other side, then there would be a contralateral loss of these functions. So for instance, if you have a lesion right here, which is on the right side of the brain, then the patient will present with the symptoms on the left side of the body. Next, we have the spinothalamic tract, which is important for relaying the pain and temperature information. So here we have the primary neuron with the dorsal root ganglion here, and the primary neuron synapses onto the dorsal horn of the spinal cord. And then from there on, the secondary neuron will start. And secondary neuron will decussate at ventral white commissure. So it will decussate right here and go to the other side. And it will ascend as a lateral spinothalamic tract. So it decussated as a ventral white commissure. So ventral white commissure, and then it ascended as a lateral spinothalamic tract until it hits the ventral posterolateral nucleus of the thalamus. And then from here on, again, tertiary neurons start, and tertiary neurons will go to the somatosensory cortex. Now, given that the spinothalamic tract has decussated at the level of the spinal cord, therefore any lesions of the spinal cord will cause contralateral loss of the pain and temperature sensation. Likewise, lesions in the brain will also cause contralateral loss of the pain and temperature sensation, versus the dorsal column, where lesions above medulla were causing contralateral, while lesions in the spinal tract were causing ipsilateral loss of the vibration as well as position sensation. Okay, now that we've discussed all these, there is one last point that I would like to mention. So for each of these functions, whether it's pain, temperature, position, vibration, or so on, there are specialized nerves and structures that will relay these informations. Now for the free nerve endings, which is used for transferring the pain and temperature sensation, there are two types of fibers. One is unmyelinated C fibers, and since it's unmyelinated, the transfer of information is slow. And then we also have myelinated A delta fibers, which transmit the information very fast. And the location of these free nerve endings is in the epidermis. The other form of structures that are used for the transferring the fine touch, vibration, as well as position sense, all of which are in the dorsal column, are composed of the Meissner corpuscles, which are large myelinated, and they are in the hairless skin, like for instance in the fingertips or lips. And then we also have the Pacinian corpuscle, which is again large myelinated, and it's in ligament and joints, and it's for the vibration as well as the pressure sensation. And then finally we have the Merkel's disc, which are also large myelinated, and they're in the hair follicles and are used for position sense. So here I have provided you with some memory aids so that you would be able to recall the function of every one of these structures. So the Merkel discs, they were used for the position sensation. So the first memory aid is that Angela Merkel has a high political positions. With the Meissner's corpuscles, their function was for fine touch, like for instance for detecting the Braille system. So Macy's has clothes with fine touch. And then finally, with the Pacinian corpuscles, their function was for the vibration and pressure sensation. So the memory aid that I have for you here is that Pakistan is under increasing pressure. And so that is 3 memory aids to help you remember the function of the structures that are listed here. Okay, now that we are done with the discussion of the spinothalamic as well as the dorsal column, we can go through this table and summarize the findings. So the dorsal column, we discussed fine touch, proprioception, vibration as well as pressure. It decussates at the level of medulla. So therefore, any lesions that are above the medulla will cause contralateral loss of the functions that are listed here, while lesions that are below the medulla at the level of the spinal cord will cause ipsilateral loss of the function. With the spinothalamic tract, its function is for the pain and temperature sensation. It decussates at the anterior white commissure. So any lesions at the level of the spinal cord will cause contralateral loss of the pain and temperature. And then for the corticospinal tract, which is for the movement purposes, it starts in the motor cortex. It was synapsed into the cell body in the anterior horn, and then from there on, secondary neurons will go to the neuromuscular junction. So let me show you on the image here. So the information for the corticospinal tract starts in the primary motor cortex, which is shown right here. And from there on, they would continue going until they hit the medulla, just like the dorsal column, decussate, and then continue going until they reach the anterior horn of the spinal cord. And then from there on, the secondary neurons start and go to the neuromuscular junction and induce the muscle contraction. So as I discussed, they would decussate at the level of medulla. So therefore, any lesions of the corticospinal tract that are above the medulla, since they have not decussated yet, it would cause contralateral hemiparesis. While lesions that are in the spinal cord, they have already decussated. So here we had them. Let's say here is the medulla. So we come here and then it decussate goes down. So any lesions that are above the medulla, it will cause contralateral loss of the function. while any lesions that are in the spinal cord, which is below the medulla, will cause ipsilateral loss of the function. So here, lesions of the spinal cord will cause ipsilateral hemiparesis. Alright, now with this information in mind, now we can go through the lesions that I've shown you earlier. So in this first condition, we have lesions in the anterior horn of the spinal tract. So here we have lesions of the anterior horn. And the two conditions that are associated with lesions of the anterior horn are polymyelitis, which is caused by the poliovirus infection, as well as Wernicke-Hoffmann syndrome, which is an autosomal recessive disorder. And so, since the anterior horn is destructed in these patients, and then anterior horn is part of the lower motor neurons, therefore there would be a lower motor neuron symptoms. Like for instance, they would have fasciculations, muscular atrophy, and flexed paralysis. The next condition is amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease, and this condition is thought to be due to mutations in the superoxide dismutase gene. Now, with the ALS, there is both upper motor neuron as well as lower motor neuron symptoms. And the reason for that is that the lower motor neuron symptoms are coming from the lesions of the anterior horn of the spinal tract, while lesions of the corticospinal tract are causing upper motor neuron symptoms. So here we have the corticospinal tract, while here we have the anterior horn that gives rise to the lower motor neuron. And so symptoms of lower motor neuron, as we just discussed earlier, include, for instance, the fasciculations as well as flexed paralysis, while symptoms of the upper motor neuron include the hyperreflexia as well as spastic paralysis. And then you should also note that the cognition, sensation, as well as the oculomotor function remains intact in patients with ALS disease. Now, in terms of the treatment, you can give these patients riluzole, which decreases the presynaptic glutamate release, and it has been shown that it increases survival in patients with the ALS. The next condition is tertiary syphilis, which is causing Tabes dorsalis, with a degeneration of the posterior column. As a consequence of which, since there is loss of proprioception, these patients will have a positive Romberg test. So for the Romberg test, you will ask the patient to put their feet together, stand while closing their eyes, and if they have degeneration of the posterior column, then they would sway, and that would be a positive Romberg test. Now, just to remind you, the presentations of the primary, secondary, and tertiary syphilis. So primary syphilis presents with cankers, which present as painless ulcers in the genital areas. The secondary syphilis presents with the maculopapular rash on the palms and soles, and then they also present with the condyloma lata. And then finally, the tertiary syphilis presents with gammas, which is shown right here. It has a center with a coagulative necrosis, and then epithelioid cells are surrounding it. It also has aortitis due to the destruction of the vasa vasorum. So here we have the vasa vasorum, which supplies the adventitial layer of the aorta. And so if the vasa vasorum is destroyed, therefore these patients will develop aortitis. They also have Tabes dorsalis, which I just discussed. And finally, Argyll-Robertsonian pupil, also known as prostitutes pupil, because they accommodate but do not react to light. So for the fact that they accommodate but do not react, the name prostitutes pupils has been given to it. So it accommodates but do not react to light. In any case, so these were the symptoms, and then the Tabes dorsalis is one of the symptoms of the tertiary syphilis, as a consequence of which there would be loss of position as well as vibration sensation. Next, we have the vitamin B12 as well as vitamin E deficiency, which causes both the loss of the dorsal column as well as the lateral corticospinal and spinocerebellar tracts. So lateral corticospinal as well as the spinocerebellar tracts are lost in these patients. And so consequently, they would present with ataxia as well as loss of their position and vibration sensation. The next condition is syringomyelia, where there would be cavitation in the cervical spinal cord. So an example of which is shown here. So due to the cavitation, it would cause damage to the crossing fibers of the spinothalamic tract. As a consequence of which, since spinothalamic tract relays information regarding the pain and temperature, therefore there would be bilateral loss of the pain and temperature. And there is usually a cape-like distribution of the loss of pain and temperature over the shoulders. Now in later stages, the cavitation may also affect the anterior horn of the spinal cord, as a consequence of which these patients also develop lower motor neuron symptoms, like for instance the flaccid paralysis at the level of the lesion. Next, we have the Brown-Séquard syndrome, which is from a hemisection of the spinal cord. So since half of the spinal cord is damaged, we will have lesion of the dorsal column, spinothalamic tract, as well as corticospinal tract. All of them has been damaged in this area. Now, you may recall from earlier discussion that we had that lesions of the spinal cord with the dorsal column, it will present ipsilateral. Likewise, lesion of the corticospinal tract presents ipsilateral. While spinothalamic tract, since it has already decussated in the ventral white commissure, therefore it would have a contralateral symptoms. So dorsal column was for the vibration and sense, so therefore in these patients there would be ipsilateral loss of position and vibration sense. Spinothalamic was for pain and temperature, thus there would be contralateral loss of the pain and temperature. And then finally with the corticospinal tract, which is for the motor function, there would be ipsilateral hemiparesis. So let me show you in the table that we had earlier. So with the dorsal column, the lesions of the spinal cord cause ipsilateral loss of the vibration and position sense. With the corticospinal tract, lesions of the spinal cord again cause ipsilateral hemiparesis, while with the spinothalamic tract, lesions of the spinal cord causes contralateral loss of the function because there has been decussation at the level of the anterior white commissure. The next condition is the occlusion of the anterior spinal artery, as a consequence of which all this frontal area has been destroyed. Now, this lesion, however, spares the dorsal column. Thus, the sense of the vibration as well as proprioception remains intact in these patients. However, because of the destruction of the anterior portion of the spinal tract, there would be bilateral paralysis due to damage to the corticospinal tract, and then there would also be bilateral loss of the pain and temperature due to the damage to the spinothalamic tract. So that would be the two symptoms of patients with the occlusion of the anterior spinal artery. Due to the damage to the corticospinal tract, there would be bilateral paralysis, while due to damage to the spinothalamic tract, there would be bilateral loss of pain and temperature. And that concludes our discussion of the spinal tract lesions.